In 1999, the Artemis I was created. It was a very interesting machine because it reversed the water bath. Now, all of you who know, we used to do ultrasound with the patient lying down, have a water bath on his head, over his eye, and we used to hold a UBM probe over his eye, and we'll do all the scans. And that was very imprecise and very, very crude. So what they did for the Artemis one is they turned everything upside down. They reversed the water bath setup, and they designed a headrest so the patients would actually lie down and immerse their eye in a water bath. So that was revolutionary. Also, the patient could see the target and the eye could keep still, and the probe would move from left to right, up and down in different angles to scan different axes of the eye. Now, I got involved with the Artemis II in 2006 because I started looking at implanting ICLs. And the most important thing about implanting ICL is the sizing. Now, I really enjoyed the Artemis II, even though it was difficult to use, but it gave superb results. The only thing was that the technology was good, but maintaining the machine and getting it serviced and getting it was very difficult all the way from Singapore. But I managed to do it. And unfortunately, about a year and a half ago, this machine started to give trouble. But I was very lucky because the Artemis III, or the Insight 100, was created. Now, this machine was a much better machine than Artemis II, much more user-friendly. And unfortunately, you still have to wear an apron because occasionally the water would leak and you would still get a little bit wet if you didn't wear an apron. So you still had to lean forward and still had a water bath, but it was much simpler to use, as you will see later. Now, the Insight 100 machine is an excellent machine. Now, I'm just a normal, plain old ophthalmologist. I'm not smart, so I surround myself with smart people. And in the center, you see, of course, Professor Dan Reinstein, and he's one of the smartest people I know. On the left, you know David Chang, and he's a cataract surgeon from San Francisco area. So I surround myself with very smart people, and I learn from them. Now, the Insight 100 machine is an excellent machine, but with Dan's applications, as you will see later, it becomes a superb machine. Now, the Artemis Insight display is very, very simple, and later on I will show you a video of how it's used and how fast you can get an on-axis fixation image of the anterior segment of the eye. Now, what about the accuracy? As I told you, the Artemis was created with superb accuracy. The epithelial thickness measurements repeatability was 0.7 microns. The corneal thickness repeatability was 2.3 microns. And the equator of the lens diameter was 130 microns amount of variability. Now, if you compare with the rest of the UBM machines out there, you can see that the Artemis one was pretty good, but the Insight 100 was the best. Everything else is inferior to that for the measurement of angle to angle and sulcus to sulcus. This was a study done by Carlo Lovisolo. Now, I'm not in a research center, neither am I in a university or public hospital. As a private practice ophthalmologist, I use the machine mostly for the following: ICL sizing, diagnosis of form frust, keratoconus, and ectasia, to view behind an opaque cornea, angle closure glaucoma when the cornea is very cloudy, and lens subluxation or loose zonules. Now, ICL surgery, sulcus to sulcus measurements. When I started looking at phakic IOLs, the most important thing I gathered from all my research was the effect of sizing, especially for lenses in the posterior chamber. That means posterior chamber phakic IOLs. Now, if you look at ICL complications, and this was from the FDA study, you could see that there was endophthalmitis that occurs in every intraocular procedure. Cataracts, that usually occurs if your ICL is undersized and is lying on the lens. Glaucoma, oversized ICL, angle closure glaucoma. ICL subluxation, again undersized ICLs, and endothelial cell loss, not really in ICL implantation if you have a good surgeon, and it is definitely not a problem because it's not an anterior chamber phakic IOL. So overall, size is important. Now, if you look at complications, oversizing resulted in 2% of complications. Cataract occurred in 1%. Now, when you see this, your heart sinks. This is my patient. And this occurred because my Artemis II broke down and I didn't receive my Insight 100. And this was a period where I had nothing else but to try and use it only with white-to-white measurements. And this patient turned up 1 day after surgery. I felt so bad. I took out the lens, and this patient, I lost this patient because she refused to have another ICL implanted. She said, I don't want to take the risk anymore. I'm nervous now, and I'm not going to put an ICL in my eye. She still sees me because I waived all her charges. Star was kind enough not to charge anything. And the end of the day, I still feel bad when I see her. She's an extremely nice woman, okay? But she understood that ICL measurements and sizing was always going to be difficult. Now, if you have an ultrasound like the Artemis II or the Insight 100, it's so easy to measure the sulcus plane and the zonular plane. It's extremely easy, especially with the Insight 100. Now, I'm going to show you this. This is from the very beginning, real time, no editing. My optometrists are there. Jessica is measuring the single measurement right across the horizontal axis. It's starting now, and you can see the water bath. If you look at the screen here, you can see the water bath, water going up, and I'm focusing now on the eye. The chamber is filling up with water. The patient is now going to be asked to open her eyes, and now she opens her eyes. I tell them it's like opening your eyes in a swimming pool. So you open your eyes, it doesn't hurt, it's normal saline, it's very comfortable, and now my optometrist will start to scan the eye. This is in the automatic mode. Dan tells me that if I use a manual mode, it will be 10 seconds faster. But it's already fast, so I think in 10 seconds it's not going to matter that much. The probe, you can see, is moving from left to right, and you will see an image of the anterior chamber appear there. You can see it just appear there. And it's done, I think, less than a minute and a half. Now, the water now will slowly drain. You tell the patient, don't remove the head or not the water will spill. So you can see the water draining. And she's finished one horizontal scan, no editing, all real time. Now, for those of us who know Dan, he is a really smart guy, and he's created this calculator with all the measurements from the Artemis or the ICL or the Insight 100. You can get this image and you can see all these numbers. There is a software update to this machine where the figures are placed in it for you. Now, all of us want to see this. We do a scan after ICL surgery, and you can see the foot plates. You can see every aspect of the ICL. In this case, she is 477 micron vault. You can see the foot plates, and you can even see the angles of the anterior chamber. Now, correlation of anterior segment dimensions and ICL applications. Now, Dan is going to go through this in much greater detail. Suffice to say that there is a very poor correlation between white to white and STS, which is sulcus to sulcus. In other words, when they tell you white to white gives you this dimension of ICL you're supposed to use, it's not going to be accurate. Now, this is a study done by Lovisolo again, and this study showed that in 54% of patients, using the white to white method, you are not using the ideal lens size. In other words, 54% of your patients would have got a lens size that is either too big or too small, but they are still okay, but not the ideal lens. So in 50%, less than 50% of the cases, you have put in an ideal ICL size. But in the remaining, you're now stuck with an ICL that's slightly too big and slightly too small, or very much too big or very much too small. Now, if you have less than 90 microns depth, you basically end up developing cataracts. So you have a theoretical risk in white-to-white measurement sizing of 36% of getting a cataract. Now, I did a small study myself for the Artemis II and the Corneal STS, and we found a relatively poor correlation for smaller diameter eyes. You can see that, or smaller sulcus to sulcus eyes, you can see that the corneal underreads. And if you look at the bigger eyes, you can see that the corneal overreads. If there is perfect correlation between the corneal and the Artemis, both lines should be perfectly parallel. And you can see the upper pair is the Artemis, maximum and average diameters. And you can see the corneal, average and maximum diameters. And you can see a rather poor correlation. Epithelial thickness measurements. This is what Dan is going to talk a lot about. So I'm going to skip through this, except to show you that in early keratoconus detection, you are looking for epithelial thinning. And I used their program inside the Insight 100 called the Reinstein-Silverman Keratoconus Evaluation. And if you look at the patient here, you can see the topography on the right here, up here. It looks very suspicious. You know, is this asymmetrical astigmatism? Is there a small little cone developing? Well, I used his evaluation application, and you can see that there is a risk score that is in red that tells you that this patient most likely has early form thrust keratoconus. The other eye is relatively normal, but again, there is a risk score over here that is beyond the red bar. So in this patient, I did trans PRK with cross-linking, full cross-linking. Now, Dan is going to talk a lot more about avoiding ectasia from false negatives and false positives. You can also measure LASIK flaps with the Insight 100, epithelial flaps, and high myopic LASIK flaps. However, we all know that the corneal OCT is easier to use. But if you had to buy a machine, one single machine, then I would still buy the Insight 100 because it can be used for ICL, it can be used for LASIK, it can be used for a lot more things, glaucoma measurements, so you cover a lot of area. Whereas a corneal OCT can measure corneal OCT, and it has great difficulty measuring. In fact, it's impossible for it to measure sulcus to sulcus measurements. Epithelial maps from corneal OCTs are not as refined and not as accurate. And this is a patient who we measured the global epithelium over the whole eye, corneal stroma, corneal base, and epithelium, and all the rest of the parameters, as you can see. And it's very, very obvious that to see that the epithelium is thicker inferiorly than superiorly. Now, I never noticed this in my OCT maps. Until I saw this, then I went back to my OCT maps, and then you can see it, but it's very, very subtle there. Now, what's the difference between corneal OCT epithelial measurements and very high frequency digital ultrasound measurements? Well, the OCT measurements are found to be thinner, and because the measurement of the OCT includes the tail film, and the true difference is likely to be about 4 to 6 microns. Now, something that is out of the cornea but towards the back of the eye is lens subluxation and loose zonules. Now, in this patient, when I saw this patient, I could see that the lens edge was a little bit exposed, and I was wondering whether there were zonules or not. So if you do an ultrasound scan with the inside, you can actually see the zonules, both anterior zonules and posterior zonules. In glaucoma, you can do a lot of glaucoma studies. I'm not a glaucoma expert, but I use this sometimes when I need to measure when the cornea is really swollen and cloudy. And you can see angle closure or open angle glaucoma or other features like a zipped up angle, as in neovascular glaucoma. Now, what about opaque and diseased corneas? I'm trained corneal surgeon, so I see some patients like this. And I developed a very small designed, specially designed speculum. It's made by Inami, and it's really tiny, and it can sit right in the seal. So there's no leakage, and it doesn't interfere with the ultrasound scan. The size is really small. It's the size of an SD card, as you can see here. And this is the normal speculum in blue. This is my design of speculum, and that's an SD card. And this is a real patient of mine. This is a patient with very small open aperture because his eye has been ravaged by a squamous cell carcinoma of the cornea and conjunctiva. Now, I started with the last slide, very sorry, because I was running through my slides, and this is basically what I want to say. Very high frequency digital ultrasound scanning will make corneal refractive surgery, phakic IOL, and IOL surgery much safer. Thank you very much.